Hello everyone, and welcome to this online press briefing, Antimicrobial Resistance, a Major Global Health Threat. My name is Jean-Yves, and I serve as Pharmaceuticals Policy and Project Officer at Healthcare with Oldham Europe, where I oversee a work program on pharmaceuticals in the environment and its impact on the development and spread of antimicrobial resistance. I will be moderating this online press briefing. I'm happy to say that we have over 75 people registered for this webinar, with participants coming from countries as diverse as Argentina, Canada, Denmark, Indonesia, Tanzania, and the US. This online press briefing aims to bring increased media attention and awareness of the AMR threat that is increasingly impacting both healthcare and the global economy in a run-up to the World Antibiotic Awareness Week that is taking place next week globally. It also seeks to highlight the environmental component of antimicrobial resistance in the framework of a One Health approach. During the press briefing, we will launch on a website a press kit giving background information on AMR and highlighting its environmental aspects. This kit will also include key data points and figures, quotes from leading experts, and compile significant reports on AMR to help journalists talk about these major health threats. You will receive a copy of this press kit by email later on. The online press briefing will take the form of a lively interview with two high-level speakers. Our first speaker is Professor Dame Sally Davies, the UK Special Envoy on Antimicrobial Resistance and former Chief Medical Officer for England. She connected to the platform through the account of her diary manager, so she will be featuring here as Mia Hashim. As UK Special Envoy on Antimicrobial Resistance, Professor Dame Sally represents the UK government on AMR internationally and works across all government departments within the UK, advising on both policy and the delivery of a One Health response to AMR. She has recently taken on this role, having previously served as Chief Medical Officer for England and Chief Medical Advisor to the UK government for 8 years. She was also a co-convener of the UN Interagency Coordination Group, the IACG, set up further to the 2016 UN General Assembly. She now serves as Master of Trinity College, University of Cambridge. Our second speaker is William Gaze, Professor of Microbiology at the University of Exeter Medical School. Will is a molecular microbial ecologist with more than 15 years of experience in the evolution of antibiotic resistance in natural and foreign environments. He has a particular interest in how biocides and detergents may co-select for resistance to clinically important antibiotics. With his group of researchers, he covers fundamental issues of AMR evolution in the environment using both in situ and in vivo experiments, landscape-scale dissemination of AMR, and human exposure and transmission studies. This online press briefing is targeting journalists, but is also open to all stakeholders. We very much encourage interactivity during this session, and we welcome any questions you would like to submit to our expert speakers. All participants are muted, but if you'd like to submit a question, please send it to Healthcare with Oldham Europe using the chat box at the bottom right of your screen. Please note that the webinar is being recorded and that the recording will be published on the website afterwards. Before we dive into our topic, I'd like to give you a short introduction about who we are and what we do at Healthcare with Oldham Europe. Healthcare with Oldham Europe is the European part of a global non-governmental organization with regional offices in the US, in Europe, and in Asia. Our mission is to transform healthcare worldwide so that it reduces its environmental footprint, becomes a community anchor for sustainability, and a leader in the global movement for environmental health and justice. We have 142 members in 29 countries of the WHO European region that includes European hospitals, healthcare systems, healthcare professionals, local authorities, research and academic institutions, and environmental and health organizations. We bring the voice of healthcare professionals to the European policy debate about key issues. Our Safer Chemicals program aims to reduce chemical pollution and exposure from the European healthcare sector. Our climate-smart healthcare program seeks to decarbonize the European healthcare sector and increase resilience to climate change. Our sustainable food program seeks to increase sustainability of food production and consumption in European healthcare. Our Safer Pharma program, which is the one I'm leading, seeks to reduce the presence of pharmaceuticals in the environment and exposure to AMR. and our sustainable procurement program aims to reduce the negative environmental, social, and health impact through European healthcare procurement. We work on these areas in close cooperation with our global network of green and healthy hospitals, the GGH Network, that is made of more than 1,200 members, representing 36,000 hospitals and health centers. Let's now delve into our topic, antimicrobial resistance, or AMR, a major global health threat. I'm very happy to welcome our two speakers, and I will start with the first question for Sally. Sally, could you explain to us a little bit more what exactly is antimicrobial resistance?
Thank you. I'm honoured to be part of this, particularly in advance of World Antibiotic Awareness Week. Well, antimicrobial resistance, and I'll now call it AMR, I hope you'll forgive me, is when microbes, which may be bacteria, they can be viruses and fungi, become resistant to the treatments we give them. Some people call it drug-resistant infection because it's the bugs of all sorts that become resistant to our treatments rather than the people or otherwise. And so I'm going to try hard not to be technical, though I'll use the term AMR. Of course, this happens naturally. It's all about Darwinism, survival of the fittest. If you face a microbe with something that's going to kill it, it will be able to mutate. And one of those mutations in it may well give rise to resistance to that treatment. And then those bugs will proliferate. So it is really a natural phenomenon that bugs, when they meet things that kill them, start to find ways round it. But let me just take one group, bacteria and antibiotics. Antibiotics are the backbone of modern medicine. If we don't have them, we'll go back to a time when simple scratches could leave us vulnerable to infections that could die. And so we use them to cover big operations, cesarean sections, new joints, abdominal operations. We use them routinely in cancer treatment. Diabetic patients get more infections. They need them. The whole of modern medicine is at risk as resistance in these bugs goes up and up. And it is going up. I'm in Canada today, and they 2 days ago published a report showing that already they have 26% of bugs with resistance and 5,500 deaths every year, which is costing their economy $2 billion Canadian dollars. So that's the human side, and we know that excessive use, inappropriate use of antibiotics drives these mutations, drives this resistance, and risks people's lives. But of course, we call it a One Health issue. It isn't just that we use antibiotics and have infections and illness in humans. We use them in the food chain, spraying crops, raising animals, and also in pets. In raising animals, we have the additional concern that not only are antibiotics used to treat infection, but in many countries, antibiotics are used to cause growth promotion because it's cheaper than preventing infection. And as we use these antibiotics, they then run out into the environment. Animals, including humans, pee or poo out about 80% of an antibiotic. It does its job, then it goes out into the sewage and the environment. And Will, who will speak to you, is an absolute expert on this area. I've told you it's an economic issue. Jim O'Neill did a report for our UK government and showed that by 2050, if we don't take action, we will have a cumulative loss of $100 trillion US dollars to the global economy. Canada has shown that even if they stay at their present resistance by 2050, they'll have a much greater loss to their economy, which would hit if they up it 44 billion Canadian dollars a year. So this is a big issue. But it's also a development issue. The World Bank has shown that if we don't work on this and get it right, more than 28 million people will be driven into extreme poverty by the healthcare costs by 2050 if we don't work on it. So all of the SDGs, Sustainable Development Goals, are at risk if we don't take action and sort this out. And this means we've got to prevent infection. I'm sure we'll come back to these. We need new antibiotics, yet the pipeline's rather empty, and it costs over $1 billion to bring a new antibiotic to market. So it's a really complex, multifaceted problem, just as complex as climate change, but actually could kill us all before climate change does. Thank you.
Thank you very much, Sally. I think you managed to scare us all. I will get back to a few points that you mentioned right now later on during this session. But before that, I would like to turn to Will. And Will, I was wondering whether you could explain to us what role the environment plays in the development and spread of antimicrobial resistance.
Okay, hello, and thanks for inviting me to take part in this webinar today. So, as Dame Sally said, bacteria can change, they can mutate. That's when their DNA actually, you get random changes in DNA, which occasionally can confer a benefit and therefore resistance in this context. But also, as Dame Sally said, the antimicrobial resistance is a natural phenomenon, and as such, it has been around a lot longer than we have, and that human use of antibiotics has. So we know that bacteria have been producing antibiotics for millions, if not billions of years. So it is a natural process, but what we are doing now is we're speeding up this rate of evolution, thousands or millions of fold. So as well as the mutations, there are actually resistance genes that are carried by environmental bacteria. And bacteria are very peculiar in that they don't have sex like higher organisms like animals and plants, but they can actually exchange genetic material between themselves, and we call that horizontal gene transfer. So there are resistance genes out there in environmental bacteria which have actually been mobilized through this process called horizontal gene transfer to human pathogens. So, these E. coli and Klebsiellas, these types of gram-negative pathogens that are now pan-resistant and are killing people, they used to be susceptible. They didn't used to have these genes. These genes have come from somewhere else. They didn't spontaneously appear in hospitals, and they have come from what we call the environmental resistome, which is all of the resistance within environmental bacteria. So that's really, in a nutshell, it's the origins of much of the resistance we see is due to the environment. But there are other issues to do with environmental pollution and those antibiotics that we pee and poo out, as Dame Sally was saying, that once they get into the environment, they can actually be driving evolution of resistance or selecting for resistant strains of bacteria in the natural environment. Thanks.
Very much, Will. And you mentioned the issue of antibiotics in the environment. What are the other drivers of AMR in the environment?
So there are, of course, we were talking broadly about antimicrobial resistance. So antibiotics are one type of antimicrobial. So there are other antimicrobials that they're not drugs, but they're things like cleaning products, biocides, detergents. So those can actually indirectly drive evolution of antibiotic resistance, because often we have what are called mobile genetic elements. So these are the bits of DNA that can move between bacteria, and those bits of DNA can actually carry antibiotic and other antimicrobial resistance genes like biocides. So you might have no antibiotics, but just being exposed to a detergent or a fabric softener, or say a heavy metal, because there are also heavy metal resistance genes, you can get what we call co-selection. So you can have one pollutant, but then it actually selects for resistance to multiple other types. it gets a bit complex, and this is where the complexity of microbial genetics comes in. But yes, there are a wide range of antimicrobial compounds, and actually we're now even finding out that lots of different pharmaceuticals and other human-produced molecules actually have antimicrobial properties. So there's a recent study that looked at non-antimicrobial pharmaceuticals and found that 25% of those have some sort of antimicrobial property. And given that we're discharging something like, I don't know, it's tens of thousands of different man-made compounds we're basically dumping into the environment, through our waste, that, we don't know what all of these things are doing in combination. But what we do know is that as we look more and more, we find more and more different compounds that can actually drive evolution of antibiotic resistance.
Thank you, Will. And another question for you before moving back to Sally. Could you tell us what the hotspots for the development and spread of AMR in the environment are, if there are any?
Okay, so I suppose we normally think of human waste and animal waste. So a little more than half of antibiotics used globally are used in livestock production. It varies around the world. Some it's less than half, some places more than half. But so we've got intensive livestock production is one. Dame Sally also talked about using antibiotics for treating plant diseases. So although that's quite a small amount of the total, it's actually used at very high concentration directly in the environment. So we spray tetracycline and streptomycin. These are both drugs that are used in medicine. They're not frontline drugs, but they are still antibiotics. We spray them directly onto plant crops like fruit trees and things at the type of concentration that you'd use to kill bacteria in, say, a bloodstream infection. Whereas the concentrations that are coming from livestock or from human waste are often much lower than that. So there's livestock, there's the crop production, but there's also human waste. So in high-income countries, we concentrate our waste and we treat it, but that treatment might have unanticipated consequences. That's where we mix all of the bacteria, including bacterial pathogens. We mix those with all of the industrial waste and the residues of antibiotics that are in our excreta, and then of course the treatment's not designed to remove those resistant bacteria or antimicrobials. It's designed to remove nutrients to stop eutrophication in rivers. And then, of course, we pump the water out into rivers, and then it gets disseminated into the wider environment. So I think you can think about wastewater treatment plants. There's still debate around how important they are, but we know that they are likely to be important, and also intensive livestock production. So it's really where you see concentrations of antibiotics and resistant bacteria being introduced into the environment, and where you see mixing of human with animal and or environmental bacteria. So it's this sort of selection, but also connectivity, which is a bit like infection control. We apply very strict infection control within hospitals, but then we don't seem to really translate that into infection control within the environment, because of course we have to get rid of large amounts of waste, sewage sludge application to land, and wastewater treatment plant effluent. There's something like 11 billion litres of wastewater effluent are discharged every day to UK rivers. So these are unimaginable large numbers. Thanks.
Thank you very much, Will. And getting back to Sally, we know that AMR is impacting differently some countries and regions in the world. Why is that so?
Thank you. So I just wanted to add fish farming, aquaculture to Will's list, as I happen to have a thing about fish farming. But why is it worse in some places? Well, let me just start by saying at the moment, more people die of lack of access to drugs and antibiotics and antimicrobials and die of resistance. It's just the tipping point is coming. And if you look at the surveillance data, the further north in Europe you go, the lower the problem. The further south in Europe you go, the higher the problem of resistance. And there's a direct relationship between the amount of antibiotics used and the resistance. And if you look at defined daily doses by 100,000 inhabitants, very little antibiotic is used, say, in Sweden and the Netherlands in humans, and a terrific amount in Spain and Greece. And so that gives rise to more problems and more illness and deaths in those southern countries. And so you get back to the education of doctors, but also the regulations that you can only have antibiotics because of prescription by a registered doctor or nurse are more adhered to in the north. So this carries out on across the world. If you get into parts of Africa and Asia, then the antibiotics are often bought over the counter in a market, often only one day's supply, which can drive resistance rather than a full course, and when they're not needed. So clearly resistance is much higher in, say, India and China than it is in the north of Europe or in the United States and Canada. It just depends on how the antibiotics are used, how bad the impact is. That said, if you just look at our problem in Britain, we have 165 new antibiotic resistance infections every day, causing 2,200 deaths that we know about. And so despite a lot of effort in Britain and the use of antibiotics coming down 9% in the community, but going up a bit in hospitals because of increased complexity of illnesses and more old people, we're still getting a rising disease burden. This is really difficult. And so for poorer countries, low-income countries, it's extraordinarily difficult. They have these drug-resistant infections, so they pile in with more antibiotics. Or someone gets ill in the community and they go and buy the treatment, but not a full course. We mustn't forget resistance to malaria, resistance to TB as great scourges of humanity across the low and middle income countries as well. Thank you.
Very much, Sally. And you mentioned before the use of antibiotics in agriculture. What progress has been made on this in Europe and globally? And do you think this is enough?
Clearly, it isn't good enough yet, though we have made a lot of progress in Europe. In 2004, or maybe 6, I can't remember which, we had a European law that we must not use antibiotics for growth promotion, and antibiotic use has gone down. But even then, again, we have in Europe this north-south difference in use, and the Swedes and Norway use much less than the South does. But you can do something about it. Over the last 4 years in the UK, voluntarily, our food-producing animal production has reduced its use of antibiotics by 53%. I'm terrifically proud of how they've managed to reduce it. And that's not because we said we'd regulate them if they didn't. They understood the need. The Americans are steadily phasing out growth promotion and reducing it. But if you want to phase out the use of antibiotics, you have to have, as Will said, the same as in hospitals, scrupulous infection prevention and control. And in the animal chain, it's called biosecurity, but it's essentially the same. In humans, we add vaccines to it. In fish farming, you can add vaccines to it. The Norwegians and Scottish fish farming now use a mixture of 3 vaccines given to tiny salmon and trout and they use next to no antibiotics. We need to spread this good practice across the world and develop different fish vaccines for different fish, whether it's sea bass or tilapia or whatever. And so there are a lot of things we can do, but it's still a long, long way to go. Thank you.
Many thanks, Sally. I'm receiving a few questions through the chat, and I would like to remind everyone, all participants, that if you'd like to submit questions, please send them to HCWH Europe using the chat box at the bottom right of your screen, and we'll try to submit them to our expert speakers. And the first question we receive comes from Bertrand, and it's directed to you, Will. And Bertrand is wondering whether you could explain what are the most efficient measures and where to apply them first to control the release of AMR in the environments.
Yeah, that's a good question, and it's a question that we hear more and more, I think, when, as a scientist now interacting with policymakers and regulators. And it's always quite difficult. But I think if we look globally, you know, we know that still something like 1 to 2 billion people don't have access to basic sanitation, so to a toilet. So even things like having composting toilets that that compost effectively be useful intervention. Some big cities around the world, you know, have very low sewer connectivity, so the rivers running through those cities essentially are acting as sewage systems, you know, and if people are still reliant on that water for, you know, sometimes washing or bathing or even then downstream irrigation, you know, this idea of connectivity and infection control, and some people call it contagion. You know, Dame Sally was saying that we know that antibiotic resistance is related to usage, and there's some very nice work that's been done to show that that holds true in high-income countries. But as you go down the income scale, this relationship between usage and AMR is less strong, and it's thought that's because of this, you know, many more or much greater opportunities for cross-contamination, for environmental transmission, for example, through the food chain or through direct contact with the environment. So, you know, improvements in sanitation, improvements in water treatment. You know, people have also looked at where humans live in very close proximity to their livestock. You know, within the same sort of physical living environment, that there's obviously more opportunity for transmission between animals and humans. So, you know, there are lots of things that we can do to reduce this opportunities for transmission, but also reduce the opportunities for selection or evolution that's driven by environmental pollution. So, you know, we know that can be very expensive. For example, there have been back of the envelope calculations based in the UK. So what would it cost to upgrade all of the wastewater treatment plants in the UK to a level that removed much of the bacterial load or antibiotic load? And it's something like £40 billion, which, you know, sounds incredible. Although apparently, you know, if you spread that over 5 or 10 years and you look at the number of households that are paying water bills, you know, you get into the tens to low hundreds of pounds per household. That, you know, even that high amount of investment would cost. But I think, yeah, you can start to see where you can. There are some basic, effectively biosecurity or infection control approaches that can be used in the wider community that can reduce some of these risks. Thanks.
Very much, Will. Sally, I wanted to get back to something you mentioned before. You talked about the fact that the antibiotics development pipeline was getting dry. So why is there such a gap in the development of new antibiotics, and what can be done to foster R&D in this area?
Thank you. Let me again pick up on something Will said. I learned so much from him. One of the things I'm excited about is the work that Bill Gates is funding on waterless lavatories. And I think that if those really come through. He's got 3 different projects. They may well help us in reducing release of both antibiotics and bacteria that may have resistance into the environment. So I hope he keeps going on that. But the empty pipeline. Well, we have what's called a classic market failure. If you look at what health systems pay for antibiotics, it is peanuts. How do pharmaceutical companies make their money? They either make them on blockbusters for cancer, where they can charge a terrific amount, and because it obviously saves a life, and they do well on that, or on people who have a chronic disease where they need treatment every day for the rest of their life, whether it's HIV, high blood pressure, diabetes, and then they only need to make a few pennies or cents on every pill, but it piles up over the weeks, months, and years. And if you think about antibiotics, we pay peanuts. Most people don't even have one course of 1 to 2 weeks in a year. And then you have that risk that once you put an antibiotic on the market, it will at some point drive resistance, and you might not even see that drug going through to the end of its patent life selling well. After all, people like me, when we get new antibiotics, say, let's save them for the really ill. Let's save them so they save lives, rather than putting them out there, piling them high and selling lots, which would drive resistance. So the pharmaceutical companies have been disinvesting, and in fact, most of the major pharmaceutical companies no longer do R&D in this field. There are still a few, and I congratulate them, but if you don't do the research, you can't bring the drugs through, and it's a question of pounds, shillings, and pence, dollars, whatever you want to say. They are not thinking about the long term, they're thinking about profit on blockbusters or chronic diseases. Thank you.
What's the solution in here, do you think? Do you think we should have more incentives for pharmaceutical companies?
We do need to. So there's been a number of incentives at what's called the push end, the R&D end, to try and get that alive again. The biggest, and we from the UK government have contributed, is CARB-X, which is funded mainly by the US through BARDA, with Wellcome Trust, Gates, now German government involvement. So that's pushing, as it were, and there are some other push efforts, GARD-P. But then we need something that pulls it through, because it's one thing finding a potential new drug, but then to get it from making it through toxicity and clinical trials and everything is very expensive. So we need what are called pull incentives, and that's proving extraordinarily difficult. We really need to separate, and it's called de-link, the development costs at the beginning from the price, because we don't want it pile it high and make a few cents on it, and that's called de-linkage. We need pull incentives. Jim O'Neill, in his famous review published in 2016 that I asked our Prime Minister to commission, suggested prizes, as it were. We're looking at other models. In fact, in the NHS, we are setting up a pilot for 2 new antibiotics to try a different way of funding them, essentially by subscription, relating to the value to both the health system and the broader society. So we're trying to do what's called the health technology assessment in a different way, and we're working in partnership with the pharmaceutical industry and the health economists and others. It'll be very interesting to see where that ends up. It's quite complex. But what we actually need is a new mechanism, and we need new funding. And so far, try as I may, I haven't persuaded governments to put lots of new funding in. I think pharma themselves need to step up. And I think they need to, not because it doesn't make a profit, but A, they owe it to society to help them, at all. And B, I think they're being very short-sighted. Many of their blockbuster drugs are in diseases where people get more infections, diabetes. Many of their blockbuster drugs cause people to get infections, their new cancer drugs and everything. They're not thinking about protecting their drugs they've got and therefore protecting their bottom line. And they really ought to think about doing that, even if they don't accept they have a responsibility to society. Over.
Thank you very much, Sally. And Will, I would like to ask you something as well related to the role of the industry, because we know that pharmaceutical companies are contributing to the problem with manufacturing pollution in overseas countries, mainly in India and China, which are manufacturing antibiotics, active pharmaceutical ingredients. So what is the role of manufacturing pollution in the development of AMR, and what can be done to address this issue?
Yeah, that's an interesting question, and it's something that's quite topical. I was recently in Kenya for a low middle-income country-focused meeting on antibiotic and pharmaceutical pollutants, and some of that is, of course, driven, as I said before, by like lack of sanitation and sewer connectivity. But in places like India and China, which together those two countries produce 90% of the world's active pharmaceutical ingredients for antibiotics, you know, this is a significant issue. There's a group in Sweden led by Joachim Larsson who did some of the first work looking in India, in Hyderabad, where some of the environmental concentrations were measured up to something like 30 milligrams per litre. It's hard to understand what that means, but that means essentially that the concentration of antibiotics in the water that was impacted by the effluent was the same as you would try and achieve in blood plasma during something like a bloodstream infection. And they also calculated that there was as much antibiotic being discharged from one pharmaceutical treatment plant in one day as was used in Sweden in 1 year. So they're quite localized, I suppose, you know, in terms of their impact, but the environmental concentrations are hundreds or thousands of times higher than they are from, say, municipal waste, from human waste that goes through a wastewater treatment plant, for example. Although, having said that, we have quite a high-income country-centric idea of what those environmental concentrations are. And new work, I think, by Alistair Boxall and his group at the University of York in the UK have shown that there are widespread elevated concentrations around the world, but they're still significantly lower than these manufacturing-associated wastes. So that sparked a lot of interest. So actually, ironically, I submitted a grant proposal earlier this week to actually work with Indian partners as part of a UK-India research program on antibiotic manufacturing waste. So it's being taken seriously. So we will see, but we see that some of these resistance mechanisms or resistance genes emerge in places like India and China, which also produce lots of antibiotics. So do they have a role in the emergence of resistance, from this environmental reservoir that I was talking about before? Very possibly. So this is something we really need to look at in more detail. Thanks.
Thank you very much, Phil. Sally, so we talked about antibiotic use in agriculture. We're talking about AMR in the environment. We have actually an interesting question from Yehold here. And Yehold is saying that it appears that most cases of deadly AMR in humans is due to hospital exposure. So why should we adopt such a broad focus addressing the issue in the environment, in animal farms, and so on, when the issue appears to be most isolated and like in hospitals and healthcare facilities?
Thank you. That's a very good question. And of course, what it raises is the fact that when you're talking about a complex One Health problem, one should never apportion blame, because whoever is driving most of it, we're all in it together. And it's true that it is the human use, and particularly in hospitals, that at the moment appear to be driving resistance, particularly. But just because the biggest problem at the moment is there, does that mean we should do no more elsewhere? You know, we know that it's being driven naturally and has been ever since the Earth existed in the environment. We know that it happens in animals, and you can pass bugs and genes through the food chain. We need to work on all of this, because if we don't, and we just try and sort overuse in hospitals and the community, we may one day wake up and see that we missed out on some important things. And, you know, they are spraying citrus trees in Florida and California with streptomycin. Now, that's a drug that we don't often use, but it is a last-line drug for resistant TB, horrible as it is, and we do need it to save lives. So if we get resistance happening in those citrus areas, and it does then move across, it would be a dreadful thing. And I would highlight that it isn't just hospitals in humans. If you look at malaria, if you look at TB, and you look at other illnesses, cholera at the moment that started in Hyderabad and then moved into Pakistan, it has happened in the community that the resistance developed, and then people go into hospital. The final thing I'd say is it doesn't matter where you get the resistance from, but we do acquire resistant bugs and genes as we travel, as we eat, whether we get it from the environment, and they exist in many people's microbiomes. That is, our friends, the bugs, in us and on us. And you all know that there are more bacterial cells in our guts than there are human cells in our bodies. Now, if you're healthy, you usually clear the bacteria with resistance in 1 to 6 months, because actually they don't have a growth advantage. In general, with not having a resistance gene and being a healthy bug has a growth advantage. But if you're someone who has one of those, and then you develop, as many middle-aged and elderly women do, a urine infection, or you have cancer and you develop a bloodstream infection, it generally comes from your own gut. And if you had a drug-resistant bug in your gut, it's quite likely that the urine infection or the blood infection will be resistant. So this is a very complex interplay with our own guts when we're healthy, how they seed infection in us, and with our travel and where it is. And so we can't afford to leave out action in the animal kingdom, the plant kingdom, and the environment. It's a truly complex One Health problem. Over.
Thank you very much, Sally. To get back to the importance of healthcare facilities in the development and spread of antimicrobial resistance, we know that in the EU, for instance, 75% of resistant infections are linked to healthcare. So what are the best practices that could be implemented at the hospital level to address this issue?
Sorry, I had to take out the question. Well, wherever you are, but hospitals are very important. Intensive farming it comes back down to starting with preventing infections, and that's really careful infection prevention and control once you've got clean water and good sanitation. I am at my wit's end. I do not understand why, even in Britain, every 5 years, we have to re-educate our doctors and nurses in how to wash hands. And that happens everywhere. You have to have strong infection prevention and control in hospitals, in all healthcare facilities, all of the food chain, and in intensive farming and aquaculture. Vaccinations play a role too in preventing infection. And it's not just vaccinations against bacterial infections. Vaccination against flu is very important, for instance, because people, when they get flu, are more prone to bacterial infections. So all of that is important. And then, when you do use antibiotics, use them knowingly, use them sparingly when they need to be. A lot of patients are ill and you think, I speak as a doctor who used to look after patients. Ha, that looks like an infection. I don't know which it is for 36 to 48 hours while we wait for the cultures to work. So you use a broad spectrum antibiotic. But 36 to 48 hours later, you should go back and stop the antibiotic and put that patient on a narrow spectrum antibiotic when you know what's grown, or say, well, I did what I thought was right, but actually it is an infection, and stop the antibiotic. We have to be very careful and use antibiotics appropriately, and in the human sector that's called stewardship, and in the animal sector it's appropriate proportionate use. So that's why we don't want growth promotion use, why we don't want metaphylaxis. We want antibiotics to be used to save lives. Over.
Can I just come in here on this whole issue about the hospital-acquired?
Yes, please go ahead, Will.
So it's very interesting, and that rationale is often used to make that exact same point that, well, if most infections in humans are caused by these human-adapted or, sometimes hospital or often hospital-acquired, then what role does that leave for the environment? Well, of course, as I said before, the resistance genes are mobile in their own right, so they can move between different strains. And what we see is that different animal species have different strains of, say, E. coli or Staphylococcus aureus or whatever the bacterial strain is. There are human and animal adapted strains. So those strains encounter each other, say in our gut or in the human microbiome, and there's exchange of genes and opportunities for exchange of genes. But, that means that you can have actually sort of classical epidemiology tells you that it's just transmission of strains between people, but it doesn't tell you where the genes, the resistance has come from. And as I said before, the resistance in many cases is not through mutation, it's through acquisition of these mobile genetic elements that are carrying resistance genes that previously weren't in human-adapted bacteria. So it's still very possible that there's a role for this whole chain of environmental selection and transfer of genes from either animal-associated or environmental bacteria to the human pathogens. And we're now learning, of course, with the sort of advent of new DNA sequencing methods, that there are these little tiny mobile elements, and they're like jumping genes, and they hop in and out of different genomes. And there are some really amazing studies that even in one ward, in one hospital, you can find the same gene in different mobile genetic elements and different strains of bacteria, different species of bacteria. And so these things are moving around in a really fluid way. So what then does it tell you if you understand that about the fact that it's just these few human adapted hospital-acquired strains? It doesn't tell you anything about connectivity to the actual, this reservoir of resistance in the environment. It just tells you that there are some very successful groups of bacterial pathogens that are good at infecting people. It doesn't tell you anything about the origins of the resistance and where that has been selected for, or where it's come from. So I think that it's a misnomer and a misunderstanding of the complexity of the problem to conclude that just because it's hospital acquired, it has nothing to do with the environment. Okay, thanks.
Thank you very much, Will. I would like to jump on this actually, because when we're talking about AMR in the environment, I often hear the word knowledge gap. So what areas of research are now urgently needed to better understand both the evolution and the proliferation of AMR in the environment?
Okay, so there's still a lot of uncertainty about the actual concentrations of antibiotics that can then select for resistance. So by select, it means favour the resistant over the susceptible strains, so the resistant ones outcompete the susceptible ones, or the non-resistant ones. So we still don't know what concentrations for many antibiotics will actually drive resistance. We're beginning to actually put some numbers on this, but often those are laboratory experiments. So when you transpose that to the natural environment, we still don't have a good idea about that. So that's I think probably the main thing. There's also then this whole chain within the whole dissemination and transmission. So if you eat food that has non-pathogenic bacteria on, but those non-pathogens have resistance genes on mobile bits of DNA, if you eat that food, what is the likelihood that those genes will then be mobilized or transferred to those human-associated bacteria in your gut? So actually, those types of interactions between microbial populations that originate in animals or the environment and humans, that complex ecology almost of AMR is still really we're beginning to understand it. And that's partly because most microbiologists, they study one strain of bacterium on an agar plate. So we have historically studied bacteria just as single organisms, whereas you can have 1 billion bacteria per gram of feces. You can have 5,000 species of bacteria in a gram of soil, all of which are interacting with each other and exchanging genetic material. So we need to study bacteria in a completely new way. We need to study them at the population level to understand what they're doing. Can you understand what bacteria do and how they evolve by looking at just one E. coli on a plate? You can get some understanding, but I would argue that actually you miss a lot of information. So it's antibiotic concentrations, it's how do bacteria actually evolve, in complex communities of bacteria, and how do the microbiomes of the natural environment and of animals, how do they interact with our own gut microbiome? Thanks.
Thank you very much, Will. Sally, my next question is for you. Thanks to you, we now better understand why the antibiotic development pipeline is dry. But can we think of any alternatives to antibiotics? We talk a lot about phage therapies for the time being now.
Well, of course, I go back to let's prevent infections. But if you've got an infection and we don't have an antibiotic, phage therapy is looking interesting, and there are some patients whose lives have been rescued with it. Interestingly, that's happening particularly in Canada and the States, whereas where phage has always been used in Russia and Georgia, they're not so hopeful that they'll have a role. So I think we have to wait and see. Some companies are looking at what you can do to the immune system to support patients and protect them, looking at monoclonal antibodies and things. So I think we will find different ways, but they're likely to be more expensive than simple anti-the-microbe antibiotics for bacteria. And we mustn't forget malaria, TB, fungi are all giving problems because of increasing resistance too. So I mean, clearly for malaria, the best is to get rid of malaria from the mosquito, or get rid of mosquitoes, or protect with bed nets. Interestingly, in TB, we used to see patients catching TB, then taking their treatment and developing resistance while on treatment. Now, patients are coming and they are diagnosed with multi-drug resistant TB, but Johnson & Johnson have got a very good drug that seems to be working for most of those patients. So it's going to be a combination of different approaches. The cheapest is going to be prevent infection. The next cheapest is likely to be new antimicrobials, antibiotics, antifungals. Thank you.
Thank you very much, and I see that the time is running out. We have 4 minutes left. So I wanted to ask which one of you, because this online press briefing is targeting journalists, how do you think journalists should communicate effectively around AMR? Maybe we can start with you first, Sally.
Thank you. It's very important that we do communicate, and the Wellcome Trust have just done a nice bit of research, so we've even got some evidence about how to communicate, and it fits with what we all knew, really. We've got to explain that it's happening now. I think some of the data demonstrates that, but it's happening now. We are undermining modern medicine. People are dying. It is undermining modern medicine as we know it. So it's not always about the apocalypse, so that may sell newspapers. It's happening now. It's happening to us. It's going to undermine modern medicine, but it's already doing that. We've got to be very clear. It can affect everyone and anyone. And actually, that's part of the stories. I met over breakfast here in Canada, the woman, oh dear, I've forgotten her name, but whose husband was had multi-organ failure from sepsis on ITU, and she, as a phage specialist, so she used a cocktail of phage, and he is walking around. Well, it can happen to anyone. We've got to be clear, but not too technical, and I hope that we've helped you understand this in that way. And then finally, we need to encourage action now. Clearly, my personal action is focused at the government level, but we have a big program in Britain trying to get people, the public, aware that how they use antibiotics matters too, and they should question doctors and say to doctors, if I've got a virus, I don't need an antibiotic. Are you sure I need it? And if doctors say they don't need it, accept it and not demand them. So be clear, it's happening now. We all have a role in this, preventing infections, getting our vaccines, only taking antibiotics when they're needed, and pushing to get something to happen. Thank you.
Very much, Sally. And now to you, Will. Because the environmental component of AMR has often been overlooked, what should be done to put it in the spotlight in the press? What do you think?
Yeah, I think it's to make the point that of course what happens within the hospitals and within the clinic is really important, but it's not the full story. And you know, this issue about the origins of resistance in some cases is quite compelling. But I think, you know, also going back to what Dame Sally was saying, you know, there are messages around personal responsibility, you know, including that taking an antibiotic is not a risk-free activity for an individual. We know that if you take antibiotics, you're more likely to suffer from a resistant infection in the future, and also it can really upset your gut microbiome and make you more likely to suffer from things like colitis and irritable bowel and bowel-related things. But there are also decisions you can make around how you use antimicrobial or biocidal cleaning products. You know, we discharge a lot of those into the environment from sort of actual household use. And then I suppose ultimately, then what food do you eat? You know, how is your food produced? Is it produced with large amounts of antibiotics, or is it produced with no antibiotics? You know, we're still uncertain about the linkages between all of these things, but what we do know that there is a probability that wherever you use antibiotics or antimicrobials, you contribute to the problem in some way. So I think that everyone can also decide about their own choices, you know, and how that affects and contributes to increasing antibiotic resistance in bacteria, but antimicrobial resistance more widely. Thanks.
Thank you very much, Will. And I'm afraid that now time is out. It is already time to conclude this online press briefing. I would like to thank very much all participants and, of course, our two speakers, Professor Dame Sally Davies and William Gaze, for their time and insightful contributions. You definitely helped us better understand the scope of the issue and the importance to tackle AMR now to avoid a scary future where antibiotics no longer work. So if you missed part of this webinar, I remind you that the session has been recorded and that the recording will be published on our website afterwards. If you'd like to keep being informed of our activities, you can go to the following link to subscribe to our newsletter and to our Safer Pharma bulletin. Many thanks once again for participating, and see you soon on another occasion.